Good afternoon, ladies and gentlemen. Welcome once more to episode 44 of our RSM webinar series for health professionals by health professionals. And this is the one in which we do all the catching up. Now then, I note that we've actually made it today's Guardian Diary. The listing of the key events of the day. We're listed directly after Nicola Sturgeon taking First Minister's questions up in Scotland. So Nicola, if you've finished and have now switched on, you're very welcome. And staying with the theme of Scotland, we have two newcomers to the panel today. First of all, Professor Eleanor Riley, one of our leading virologist immunologists, started a career at the MRC unit out in Gambia, a long period at the London School of Hygiene, moving up to Edinburgh to direct the Rvalue Institute, and she remains now the chair of Immunology at Edinburgh, a familiar media commentator in the times we live in. The only thing lacking in your CV is an appearance on our cult webinar, and now you've achieved that. And the same goes also to Professor Andrew Goddard, universally known as Bod. I don't know why, but he is the youngest president of the Royal College of Physicians in 400 years. Although, to be fair, he could still be over 80 and they make that claim. But the first one from Derby, a gastroenterologist from training and a strong list of academic publications, but it's possible you might even be one of the last members of that vanishing tribe, the general physician. And last and definitely not least, our old friend, Sir David Spiegelhalter, who brought the house down with his appearance last month. I still assume there's more work to do on his house because he's back here once again talking to us and once again plugging his absolutely excellent book. Here we are, The Art of Statistics, available in all good bookshops around the globe. Okay, now then, let's kick off. So as well as catching up on some of the questions we missed, we also got into the habit of playing a quick round of what we call Desert Island Papers. Here we go with the background music. In which I'm going to ask all of you to pick up on one thing that you've seen in the last 2 months since we last did this roundup that has caught your eye in the research literature or indeed in any literature at all, either because it's terribly good or terribly bad, but hopefully interesting. David, do you want to start off?
Yeah, this is quite tricky because there's been so much stuff that's been plopping into medRxiv and everywhere else. But I'm going to pick the Open Safely paper from Ben Goldacre's team in Oxford, which was on medRxiv and then in Nature, which essentially, took records from 17 million patients in general practice and produced a risk index indicating the risks of both catching and dying from COVID. And I think this is an extraordinarily valuable exercise. And the fact that the technology they use to develop that and the clarity and the transparency of the publication, I think is really cool.
Yeah, in fact, I used that as my Desert Island paper when we first started off, but we should have it more than once. And also the clarity of the governance, how we managed to do something that we all thought was impossible.
Yeah.
And couldn't agree more. Absolutely brilliant paper. Eleanor, what have you got?
Yeah, I'd like to talk about two papers published back to back in Cell at the beginning of the month, and particularly an overview commentary written by Pablo Cagnetti and Carola Vinuesa, and it's called COVID-19 Makes B Cells Forget but T Cells Remember. So I'm a nerdy immunologist, and so I love this kind of stuff. This particular commentary, I think, makes a lot of very complicated immunology very accessible to educated non-experts. And essentially what the two papers show is that people who've had very severe COVID have a defect in their long-term B cell response to COVID such that they probably don't make long-lived antibody responses. But that's because of the very high level of inflammation that we see in those severe cases. But in comparison, a paper from a group in Stockholm looked at T cell responses in people with mild, severe, or even asymptomatic exposure and found really all the evidence of T cell response, which will be very long lived. So I think, and the likelihood also that people who have milder infections may well have long-lived B cells because the T cell help they need seems to be there. So I think it's a very good overview, and I think it's overall, it's a rather positive set of data or encouraging set of data.
I was about to ask you that. It sounded like the Lord giveth with one hand and taketh away with the other. So it's positive overall? For what reason?
I think because, so I think the problem that we have is when we're trying to look at tissues from people who've had COVID infections to try and figure out what's going on, we obviously can only look at people who have died on the whole, and they tend to be the people who have the least useful in terms of understanding what's happening to the rest of us. So whilst those people seem to have a B cell defect, the other papers suggest that actually the rest of us, who hopefully aren't going to die of this disease, actually will make a long-term memory response to this infection.
Okay, that's cheered up. I was having to do a few noises off there, but hopefully we kept them slightly off. And Bod, what have you got?
So I don't know how everybody gets time to read papers. So the only time I generally get to read is just before going to bed, which generally lasts a couple of minutes before I fall asleep. But I've been reading Can Medicine Be Cured by Seamus O'Mahony over the last month, which I'd recommend. I mean, it's a bit polemic at times. It's one person's view. He's a gastroenterologist, so clearly I'm of the tribe, and we're going to have similar sorts of thoughts. But his views about sort of, if you like, the fakery of modern medicine, and how data has been misused, but also sort of the loss of professionalism. I think most people would find it strikes a chord with them. I wouldn't agree with everything he says, but certainly it makes us think about medicine as a whole again, and perhaps also distracts us from COVID, which is quite nice.
Yes, that's true. Okay, so we'll come back to that theme, I suspect, of medicine as a whole again, as we look at the impact it's had on education, which has come up quite a few times in the last few sessions that we have had. So now then, as well as catching up on some of the questions that we missed, we do also like to be slightly up to date. And there are a couple of stories this morning that you might like to comment on. I mean, first of all, it's the curious incident of the dog in the nighttime. Dorothy Parker, my favorite American humorist, always used to, when she picked up the telephone, always began by saying, "What fresh hell is this?" And that's what I think every time we see the Prime Minister, the Chief Medical Officer, and the Chief Scientist, the Scientific Advisor in a room together. It's always going to be bad news. Some restrictions have been increased, guidelines come law, and we're all going to be sent into the naughty corner for yet longer. But actually, nothing happened last night. And so the question for the three of you is, what do you think? Is that good policy, or is that, have we missed something, or were you surprised by that? And do you think that was an opportunity missed, or alternatively, as others have said, an increasing maturity to the way in which we approach this crisis? So why did Boris not speak? Bod?
Well, he did.
I know he did.
So a week ago, he didn't, of course. Or they spoke separately. And so we had Chris and Patrick sort of laying out the doom and gloom, and then Boris following up with the sort of the goal line tapping. And I think he had a bit of abuse earlier in the week because of perhaps not being fully briefed on some of the local rules. And I think
it's unfair, wasn't it?
Which was, I think, a bit of an unfair question. And perhaps he needed a bit of support. But I think that showing that politics and the sort of the science, if we can call it that, are sort of the same mind, of presenting a united front, was probably what that was aimed at. And I think it was good to see. Okay.
Now, David, you wrote in the Times very recently, whenever you hear the phrase, "we're following the science," you start screaming. That's a direct quote from you from last week. So did you start screaming?
Well, I actually not screaming too loud, because Boris didn't claim he was following. I hope he didn't claim we were following the science, because I think he didn't do that. He'd obviously read the article. Because you could tell that what the Chris Whitty and Patrick Vallance were saying was not. They weren't saying what should be done in these circumstances at all. It's not their jobs to say. There's a good article by Graham Medley today in the Times to say, so it's not scientists' job to say what should be done. And this media obsession between groups of scientists, trying to polarized views, arguing about policies. Obviously, some do say what should be done, but most of them are sitting there trying to work out what's going on, understanding the evidence, and perhaps working out, trying to estimate the consequences of different actions. But it's not their job to say what should be done. So I thought it was interesting yesterday because I was always looking at the tone. Clearly last week with this red, exponential growth was the thing to really, give us all the squits and to give us a shock to the media and all of us. I wonder whether that's going to come back on them. However many times that Patrick said this is not a prediction. The fact that the current infection levels are running along really substantially below that at the moment, is bound to come back on them to some extent, I think. But yesterday was, I thought, very interesting. I was trying to look, what's the gist from the scientists? It was that this is serious, this is serious, this is happening and everything like that. But also they were saying this is not like March. They were, again, emphasizing that. Something I wish they had emphasized more, and I wish they'd said, is that this is really complicated. This is complicated. And it's something that does irritate, because everyone says, oh, we've got to keep it simple. We've got to keep it simple. Well, no, this is not simple. We've got, the risks to different parts of the community, especially by age, are massively different. The risk in what's going on in different parts of the country is massively different. This is not simple. This is complicated. And I can see, I have read some, what I would argue very strongly is that I'm not going to say what anyone should do. What I do think is there needs to be much better clarity in the communication. And I thought in advance that they need a traffic light system for which areas have got what measures are being applied. Apparently that's being considered now. They should have done that during the summer. They should have worked out 5 levels, A, B, C, D, E, or 1, 2, 3, 4, 5, or red, green, something or other, so that from, you could say, well, we are moving Liverpool up to level D. And that means, and everyone knows what that means then. You've got to do X, Y, and Z and things like that. And we could all have that in our kitchen walls or something, or it could be easily available. They desperately need that. I'm glad nobody gives me a test on exactly what I am or not allowed to do. It's sitting here in Cambridge, and we've never changed. I couldn't do it. So I think this is complicated, but complicated things can be communicated if it's done. If people.
But don't we already have a traffic? Don't we already have a traffic light system? I seem to.
Yeah, but they've got a national one.
It's the national. Okay.
One. No, we need a local one, so that we know. Essentially, level D means the same. We've got a list of measures. You can even change what level D meant, sometimes, but at least we knew and we could access that information. It could be on all the websites, it'd be absolutely clear. Anyway, so that's my little bit.
Eleanor, what was your view?
Yeah, so just following on from that, Andy Burnham was on yesterday or the day before and made that point that actually now the whole country is at level 4, but within that there are lots of different things going on. And I think the idea that we have some kind of system within level 4 that lets people know what they're up to is really helpful. I guess my feeling is that back in March, April, the strategy for what they were trying to achieve with all of these restrictions on our daily activities was quite clear. It was to flatten the curve and protect the NHS. And I'm not quite sure what the strategy is now. What is it that they're trying to achieve? I think during the summer, certainly up here in Scotland, I think the Scottish government was really hoping they could go for elimination, and it looked for a couple of weeks that they might have a chance. They're clearly not trying to do that now, but I'm not quite sure, apart from keeping the schools and universities open, quite what their strategy is. And I think that makes it difficult to know when will we have achieved what it is that we're trying to achieve, because they haven't told us what it is we're trying to achieve.
Well, you've knocked off one question they had later on, which was asked of one of your colleagues, which is Scotland trying to achieve elimination? I think you've kicked that one into touch. Also then, directly leading on, and I think this is back to you actually, David, also leading on the news this morning is the latest from, I've forgotten the name of the study now, which one is it? React or, thank you, yes. Claiming that infection rates seem to have stabilised or even slightly reduced in England, but not Scotland. Now, ONS provide a similar population-based set of statistics as well. What's your reaction to that latest information, and how does it fit in with what you know ONS are producing?
Okay, there's no suggestion that infection rates have reduced. It's just the rate of increase might have reduced. I've looked
sorry,
at the paper,
stabilised actually. Yeah, sorry.
Yeah, they do produce a significant difference between the R values from a few weeks ago and the R values more recently. But I wouldn't want to overinterpret a single study. There's that, which is great to have a random survey. Rates still increasing. But ONS have got their random survey. All these pillar 4 surveys are absolutely valuable. And I would not want to overinterpret a single measure. What it does suggest, again, though, is that it is evidence, I think, against the exponential increase, the shocking red curve that was put up at the beginning of last week.
And we know it's a variable picture. So try and have one measure and say there's one story that it's stabilized in the country. That's just clearly not true. There are some places where it's getting worse, and some places where it's getting better. And we know that there are some hospitals who are completely snowed under at the moment with COVID, and it's really taken off in the past couple of weeks. And there are other hospitals which haven't seen hardly a case. So we must remember it's very variable. And I think it's a bit misleading to use a single stat for the whole of the country, because if it then affects the behaviour of people where it is increasing, that's probably a bad thing.
And to be fair to the authors, they didn't use a single stat. They did break it down into regions. We should say that because some of the authors have been on this webinar. We wouldn't want to insult them. They definitely did say that. And you've always, David, been a bit critical of the R value anyway, haven't you? You've treated it with a certain large cellar of salt.
Yeah, I'm not a modeler, and I've never been that keen on it because it's so unobservable. It's just not something you go and count or measure or something like that. So I much prefer looking at what I call the I number, or something about incidence, which has become the popular one, which is the number of cases per 100,000 per week, which is, I think people are starting to get a feel of what scale is, that anything below 20 it seems to be quite fairly reasonable, under control. They're going up 50, 100, where the country, I haven't looked at the latest data, but certainly in the Northwest, it's been, well over 100 in many areas. Now that's really, is very high. And I think that as a measure of the amount of new infections in the community is a good thing. It'd be nice if people got a feeling for the magnitude of those numbers. And again,
one thing, David,
is the variability is just huge, and that's what I again want to say. We just heard about the complexity. This is complicated. It's complicated.
Yeah.
I'm trying to solve. This is an area where statisticians, we always get laughed at for having averages. I got my feet in the oven and my head in the fridge, and on average I'm fine. Standard joke. But the whole of COVID is like that at the moment. Talking about the average mortality is almost pointless. Talking about the average risk is very pointless. It's the variability is absolutely essential part of the message.
And on that, actually, one thing it just suddenly occurred to me that I don't know if anyone's noticed, but that graph that we see about 50,000 times a day of the big Eiger-like peak in May, March, April, and where we are now, and you look at it firsthand, and it looks like we're back where we were. But they've started putting a dotted line in the middle of it to make the point that back then the true rates were much, much higher than that graph would suggest because we weren't testing. Well, David, don't you think they should perhaps now put in, from the antibody studies, estimates of actually what the transmission was like in March, April? Because every time we see that graph, even with that dotted line, it still makes us think, Jesus, we're back at square one.
No, they just shouldn't show that damn graph.
They shouldn't show it at all.
The number of tests, the number of deaths, the number of hospitalizations. No, let's see that. Let's see that one, and let's see the deaths, and let's see other, proper harder measures. But that one is such a pointless thing to show. And say, oh, we've got as many positive tests as we did back into. Oh God, it is so stupid. People must know this is nonsense. Why say it? Why even mention it?
Well, I'm so glad you're pulling your punches. Excellent. Now then, so let's get on then. So one of the episodes that we had recently, number 42, or I don't know, actually I can't remember if it was that one, but we had one on children in schools with Russ Viner and Amanda Spielman, which was absolutely excellent. But they skipped several questions that were asked, which were actually about universities on the grounds they were there to talk about schools. But if we were taking questions today, I'm sure we would be getting a lot about the situation in universities. And there are, again, various views about this, and also very different approaches being taken across Europe, and we seem to be somewhere in the middle. But I just wonder, Eleanor, your university seems to, three of us work in the universities, and Andrew, you're very connected as well. Do you feel that this was unforeseeable, or do you think this was foreseeable but unavoidable, or that it was foreseeable and avoidable what's now happening in Edinburgh to some of your students?
So I can famously say, I told you so, because I've been saying to friends and colleagues for about 6 weeks that watching, I mean, the university has done a fantastic job in setting up a COVID secure campus, and you go onto campus now and everything's one way, and there are signs, and they've got students coming in occasionally for face-to-face, but very only occasionally, but they're giving them as much of that as they can. But it was always inevitable that you can make the campus as COVID secure as you like. It's what they do off campus that is the problem. And I'm afraid that has turned out to be the case. And anybody, I would imagine, who's had teenagers in their household in the last few years knows what teenagers do and how difficult it is to persuade them not to do things that they want to do. And I said give it a month, and actually I think in Scotland it's been 3 weeks. So I think it was inevitable, but I think the universities have done what they can on campus. It's now up to the students to behave well off campus.
Yeah, I'm not one myself for blaming students for this. I think they've been given a horrible deal.
Absolutely, absolutely.
Yeah, for which they pay £9,000 a year to sit in a poor accommodation, where I believe in Edinburgh they've been locked in, which must be.
I don't think there's been any. I think they've been locked in at Edinburgh.
Was that Manchester?
Media. No, I think Napier, but not Edinburgh University. Hasn't had any.
I'm sorry.
And they've had a few cases, but not a massive outbreak in their residences so far. So
okay, but no, I think we should cut them a bit of slack. Myself, I must say, it's just such a ghastly time for them.
Yeah.
David, anything from your perspective?
No, I mean, I'm Cambridge University are obviously doing their best, but it's nothing I've been part of, I'm hopeless at making predictions, so I can't say I told you so.
Okay,
but
the great Tony Blair.
Yeah.
I'm sure it must be in your book actually, when Paxman was interviewing Blair, and Paxman asked Blair to make a prediction, and Blair said, well, the thing is, Jeremy, I never make predictions, I never have, and I never will. You just have to think about that for a minute, and it's very funny. Okay, Bod, anything you want to say particularly about anything specific?
I spent last week taking my 2 kids as part of the mass migration. So my son's at Leeds Uni in his final year, and my daughter's just started at Nottingham Trent. And I think you're completely right. They have had a really rough deal over the past 6 months. They've had the studies disturbed at the end of sort of the summer term. And for people starting university, I think it's really hard. And, I really look forward to getting out of the house to go to university when I was that age. And I think giving them the chance to do so. And we knew it was going to happen. It was predictable. Yes, it was avoidable, if you like, but I think the steps that we would need to avoid it completely would probably be too disruptive. And our kids need the chance to step out on their own, to be educated, to learn to sort of do independent learning. I think I wish them all the best, and I'm waiting for that phone call when my daughter tells me that she's positive.
Yes.
Yeah.
Okay. Right. Let's so now another set of questions. I'm afraid I can't name the people who've asked these questions now, because we've just had so many that it's not fair to ask our team to put the name of the person against it. But we've had quite a few questions on the non-COVID activity. The impact on the pandemic on non-COVID activity has come up many, many times, and several people feel that we haven't really done that justice yet. So just first of all, I think maybe David first on the kind of general picture, and then I want to ask you, Bod, on a more specific picture in medicine. We've tended to look at surgery more often, but on what's happening in a couple of the medical specialities. So, David, what's the general picture on non-COVID activity? And you've constantly pointed out this kind of dip in that graph that we're not allowed to talk about anymore. Oh no, it's mortality. We are allowed to talk about that.
We can talk about that.
Yeah, we are allowed to talk about that one. Yeah. So tell us a little how that's been panning out.
Yeah, it is interesting. I mean, we could talk about how much of the non-COVID extra mortality during the spike was in fact underdiagnosis, which I think is quite possible in the older people. But the thing I've been banging on about for ages, I think, is the excess deaths at home, non-COVID. You know, they're just not changing. You know, all the way through, we're getting 30% extra, more people are dying at home than usual, and they're not dying of COVID. And you know, I suppose maybe practicing doctors can help me on this, because I just don't know what's going on. Is this because people are not being sent to hospital or don't want to go or whatever because they're anxious or because they don't want to burden the health service? And are all these extra deaths, are they being cared for properly with nurses and good shaker? Because, you know, as I've said, I've had, you know, close family die at home, and those deaths have been as good as I can think a death could be. And so it's people dying at home is, in a sense, not necessarily a bad thing, because most people would want to die at home. I just don't know what the quality of these deaths is, and I just wonder, is anyone keeping track of this? Because there's no sign of it going away.
Well, that's a perfect cue in for Bod. I mean, you were one of the authors, weren't you, of Hospital at Home, or whatever it was, the RCP report. So, good thing, bad thing?
Oh, it's got to be a good thing. We know that when you talk about end of life, so most people, if you ask them, would say that they would like to die at home. If you then talk to relatives after their loved one has died, most people say they died in the right place, because most people do die in hospital, and actually having that additional support works. So if we can get all of the palliative care and the support at home, it's great. But I think David's made a really good point. What we saw people, they didn't want to bother the NHS. They said that. They were also scared of coming to hospital, and they remain scared. You know, I talk to people in clinic on the phone who won't come to the hospital, and they won't come for their tests, even though I think they really need it, because they're still petrified of coming into hospital. So I think we get this non-COVID tail that we're going to see is going to be very long, and I think it's going to be big. And most of us have been saying that it's going to be bigger than the COVID sort of area under the curve when we look at it in retrospect. I think we're just waiting to see it.
Just to put you on the spot slightly, I mean, the real question is, are these, I mean, I hate the word avoidable death, because death isn't avoidable, but are these things that could have been delayed? I think that's the question David's asking. Can we separate out, are these people having a better death at home, or are these deaths actually that shouldn't have happened, at least not at this period of time?
I think we don't know the answer to the question, because we haven't got the depth of data. I think what we did see was quite clearly in the first sort of 2 months of the pandemic, there were people with myocardial infarction who either didn't end up in hospital or didn't call for ambulance, or if they did, they had delayed it significantly. We saw that across the globe. So and we would therefore expect that to have a knock-on effect. We're likely to have people developing heart failure. We may well have had some sudden deaths from arrhythmia that might have been prevented if they presented with their chest pain sort of in the 24 hours beforehand. We just don't know, but I think that data will become available.
It will do. Okay. Eleanor, anything you want to say on this? Or no? Okay, fine. So, Bod, can I just pick you up then whilst you're there? I can see you on the screen. A second question, I don't know who it came from, was we talked a lot about surgical delays and problems waiting lists, etc. We haven't really talked very much about the perspective from the physicians. And we had a very specific question, which is perfect for you. How can we, or can we ever safely reinstitute or increase endoscopy and interventional operative lists? So that's aimed at you, the GI physician. What's going on?
So we're probably back to about 65–70% of lower GI endoscopy activity, bit lower for upper. So the problem with the uppers is because you need to wear a hood or fully gown up and with FFP3 masks, we can only get through a much reduced number of cases in a list. It's hard to see how we're going to get over that, because we suddenly can't magic up a whole bunch of more staff and a whole bunch more endoscopy rooms. What we have seen is some units have been, they've looked very hard at the people they're endoscoping. So do we really need to do this procedure? We should have been asking that question well before COVID. And this is another opportunity for us to say, are we doing the test that we really need to do? And I think what we're finding, certainly for upper endoscopy, that in many cases we could probably avoid it. And I think we'll end up with a lower baseline, if you like. I think endoscopy activity has been increasing inexorably over the past sort of 15 years. And I think it's got dipped down, and I think it will go back up, and it's a bit of a sawtooth. But we're going to have a lower level of activity for the next, 5-10 years or whatever. I think there is a challenge when it comes to colonoscopy bowel cancer screening, because I'm a firm advocate. I think that really works well and that really saves lives.
Yep.
So I'm quite worried about the knock-on effect. But the knock-on for diagnostics of sort of radiology imaging is also there. And I think that, again, we're going to see a long tail because of that.
So this could be an opportunity to finally get to grips with the Choosing Wisely campaign that all of our colleges endorsed. I mean, it's always amused me that you brought in H. pylori, a great treatment for the ulcers that we used to see as students, and yet you're still doing even more endoscopies than ever before. But we'll let that hang for another series. Eleanor, let's move on to you. Now, this is a kind of, I've written perineal question here, but actually it's a perennial. It's definitely not a perennial question. Sorry about that.
I'm not the right person.
That'll be me
Yeah,
again.
not the right
hardy
person, no.
perineal. Yeah.
Yes. Sorry about that. But we haven't asked it for 2 months. So we used to grill old Openshaw on this one, but now I think it's your turn. It's just how confident now, where are we with the issue of immunity to COVID after? I mean, it is such a crucial question. We should be asking every month that there is immunity to COVID-19 after a proven infection. Peter, having said he didn't know, was coming towards there might be, but 2 months is a long time in science. Where are we now?
So the only hard evidence that would say yes, absolutely, would be people who have had the infection exposed again to somebody with a high titer of virus not getting reinfected. That would show us in real life that people had immunity. But we don't see that because we don't look for it. We're not out there looking and checking whether people who've had the infection are being exposed to high levels of virus. So then we have to fall back on a sort of secondary level of evidence, which is looking in people's blood and saying, do they have evidence of antibodies? Do those antibodies neutralize the virus? Do they have T cells? Do those T cells kill virus infected cells? And the answer to all of those questions is yes. The vast majority of people who've had symptomatic COVID have antibodies. And the vast majority of the ones that have been looked at also have a very robust T cell response. So from everything that we know, we would say, yes, there is immunity after infection, with the caveat that we don't know how long it lasts. But just to continue a little, I think what we are also learning is that there are plenty of people who've had mild or have been asymptomatically infected or living with people who've been infected, who don't have much in the way of an antibody response, but have a very robust T cell response. And so what that may well mean is that the serological surveys that are being done, for example, in REACT and other similar epidemiologies, may well be underestimating the number of people who've been exposed, infected, and the number of people who are still at risk. And the other thing that plays into that is that we're also getting quite a lot of data that there's quite a lot of cross-reactivity at the T cell level with the other seasonal coronaviruses. So my suspicion is that in addition to people who know they've had it being immune for a period of time, there may be another subset of people who are just never going to get it. And again, the evidence is that within a family setting, for example, somebody can get it, can get quite sick, can be tested positive. One other member of the family also tests positive, and 2 or 3 people in the family never test positive. So I think that we almost need to start turning the question around, is not how many people have had it, but how many people are still really vulnerable to it. And I don't think we've got an answer to that yet.
Just riff a little bit more on the cross-reactivity story. Because we haven't gone into that for ages. So
we've been on the when looking for antibodies, all of the assays that we've been developing have tried to be as specific as they can be for COVID-19, because we want, when we do the test, to say you've had this one, not a seasonal coronavirus, which looks a bit similar. And so all of the antibody tests have been designed to be highly specific for COVID-19. But actually, when we look at the T cell response, we find there are a lot of shared motifs between the different coronaviruses that induce T cell responses. And quite a lot of people have those T cells. Now, we're not entirely sure that those T cells will kill a COVID-19 cells in a COVID-19 infected patient, but the likelihood is that they are going to help. So we're in this slight no man's land of not knowing who's still vulnerable, whether seasonal coronaviruses can confer some protection, and whether there are some people who didn't have, having recently had a coronavirus infection, may be actually not be very susceptible to COVID-19 for some time to come.
Well, that's not, I wouldn't say very cheerful, but it's certainly not depressing for once. That's nice to hear.
No, I mean, I think what I would say as an immunologist is there's nothing that we've seen in the data so far that gives me any major cause for concern. This looks like a classical immune response to any other infection that people get.
And there was that paper in Cell a couple of months ago that I know did please people, because it looked like this was behaving normally, and therefore in time a vaccine would be possible. In time. I mean, this looks like this virus looks like it's doing to the immune system exactly what we expect viruses to do, and on the whole that means they induce a protective response which lasts for a period of time, which may be a few months, maybe longer. And I don't know if anyone else wants to come in. Could that, I mean, it's pretty clear when you compare the speed of things in March, April to now, right across Europe. Every country is going through this, but it does seem to be slower in all the countries in Europe in terms of growth. David, is that possible that this is?
Yeah, I mean, this is one of the, if you might say, the one wing of the argument. The, I suppose, slightly more libertarian wing has been arguing right from the beginning that there is, the degree of immunity has been grossly underestimated, and that actually the patterns, right from the beginning show that there is a very high degree of some natural immunity in the population. And I've always thought, well, yeah, maybe, but I wouldn't want to base a policy on that. I wouldn't want to rely on it. But it does seem to be, this is, absolutely, the core scientific uncertainty that has led to big disputes about what's going on. I wouldn't want to say that because the slower speed of increase in infection now, that's because of a fewer number of susceptibles, because actually, the number of people with antibodies at the moment is at 6-7%. And so even if it would still, okay, if there were, it could be slower if there were fewer people susceptible, but I don't think it'd be that big. But there's so many other reasons why the increase might be slower now. We changed our behavior. We really have changed our behavior. And
that's true.
And let's remember that the curve in this country of infection was well, what's the word? It was tipped before lockdown by people's changes.
Yes. Yeah.
And so we know that while there are rules and regulations, that's fine, and the real lockdown brought it right down. We know that just the behaviour changes now that become almost institutional are going to lead to some benefit. So I don't think there's. I wouldn't want to quote this as evidence. Oh, this means that a large proportion of the populations are not.
No, I wouldn't want what I said to be taken as having said that. I think, but I think that the true level of exposure is probably somewhat higher than the serological evidence suggests.
Okay. Can I ask, Eleanor, how are we ever going to? This is, a fundamental issue of dispute among people. How are we going to know this apart from sort of challenge trials or something like that? How can we know this? And as you said.
I don't think we can. I think it will all come post hoc. We will know when we look at how things play out. I think that is the only answer, actually.
So we know that from the surveys that we've done that 21% of physicians have had PCR positive COVID and 17% have got antibodies. So you know that within a group of medics, that's the proportion that will develop an antibody response. Now, I would completely agree that there may be a proportion of this. So I'm convinced I had COVID toe. I had this thing on my toe, which couldn't be anything else, looked like all the typical pictures. I never had any other symptoms, and I'm antibody negative. So did I have it? Was it this? Was who knows? But either that or I had a very localized pernio or something, but it was typical. So I think we, as Eleanor says, I think we wait and see. But as David said, it is very different now, and that's why we're seeing a different shape.
Okay, well, let's move on to moonshot or moonshine, or whichever way you want to look at it. John Bell came along a couple of weeks ago and clearly knew what was happening, and may even been part of the inspiration. Actually, this idea of maybe next year we'll be each of us testing ourselves like we might be using pregnancy kits and things like that. But the BMJ, as you can see, we're not impressed by this. And what I wanted to do is, I want to ask a little bit about the stats in a second. I think we will just have time for, but Ellen, I just wanted to ask for your view first of all, is are we even close to having sufficient clarity in our testing to be able to run what would be a kind of mass screening exercise, once a day or once a week of 60, 70 million people? Your own National Clinical Director, David Leach, told your Scottish Herald yesterday that these tests are a bit rubbish. True or false then? Is our testing at the stage of what we are testing for anything like yet at that stage that we could think about this kind of moonshot program?
So I preface this with saying I'm an immunologist, not a virologist, but my impression is that
you know a lot about viruses, though.
My impression is that the routine testing that's done hasn't really changed since March. In other words, the way we're doing it, an RT-PCR, we're pretty much doing the same test that we were. And the problem with that is that people get essentially a positive or a negative result. And we know that it can continue to pick up fragments of virus after the infectious virus has been killed. So, again, I'm not a virologist, but my guess is that your likelihood of infecting other people depends on your viral load, the amount of virus you're shedding. And so if we are picking up a lot of people with small amounts of virus, may not still be infectious, the test that we've got isn't really helping us to predict how things are going to pan out in the future. And the thing is, we just don't know of all the people who come back positive, whether they're really infectious or not. So we need, I think, a little bit more gradation in that. And we need to be able to say you're highly infectious, you absolutely must stay at home, versus you're probably on the down curve, you should stay at home for a week, but not 2. We don't have that sort of at the moment. And on the antibody tests, my feeling is that antibody tests are not reliable enough to properly inform anybody's behaviour. So people ask, well, we can. There are rapid tests for pregnancy tests and diabetes tests, but those are incredibly accurate, and knowing the answer to your diabetes test or your pregnancy test immediately suggests that you may or may not need to go and see your GP. Whereas getting these antibody tests, again, it's positive or negative. You've no idea how much antibody, you've no idea if it protects you. I really don't see how that in itself can reliably inform your subsequent behavior.
Yeah, I know people have been enticed to think towards immune passports, but have also been persuaded perhaps the time is not right in many respects for that. Okay, David, on the same issue then, I mean, you've already talked about you start screaming when you hear politicians say they're following the science. You also told the Today programme that when you heard about this mass testing, moonshot, you were banging your head against the wall. I wouldn't like to be your neighbours at the moment, actually. It must be very noisy. But why were you banging your head against the wall?
I suppose because it's not just statisticians, but people really should be aware that mass testing or mass screening can throw up a huge number of problems. And the particular issue, of course, one of the ones is from false positives, either because, as Eleanor mentioned, you might be detecting something that's so old, an old scrag end of some infection, or just a false positive because the test is not could just throw out random false positives. Even a small rate, when you're testing hundreds of thousands, millions of people, will generate vast numbers of false positives, and that's a real problem we know in every area of screening, and that's why many things aren't screened for. Prostate cancer and all that kind of stuff. We know those problems, that they're very subtle and can be very unintuitive. So that's why I bang my head against the wall. Now, I'm not saying that people don't, or the great and the good don't understand these things, although we've seen a lot of politicians' statements about false positives and false negatives suggesting they don't understand these things. So I think, but I mean, I've been amazed looking at these PCR tests that are used in pillar for the random testing, like ONS and React are doing, which are exactly the situation where you might expect false positives because of the low prior probability of an infection, and actually generating very few positives. At the nice little natural experiment is that in the middle of July, August, when there was really we're at a nadir in terms of the infection, the number of positives there, it gives a measure of, well, if these were all false positives, that is gives an upper limit to the false positive rate, which is, like 0.04% or something like that. It looks like for these PCR tests that are being used on the pillar 4. So it really is extraordinarily impressively small. These labs really seem to be able to do this stuff pretty well. They've had a lot of practice, though. I'm sure they should be able to. I think there's what I suppose I'm meaning is that you need to be enormously careful about false positivity. The idea of you test someone, it's positive or negative, and this tells you something immediately. Yeah. We've got to get away from that idea. We know there's degrees of positivity in these tests. We know they're not absolutely black and white. And to investigate the role of repeat tests are absolutely vital to think about that, and so on. So this is not just, we need to get away from this idea of positive or negative indicates, you've got the disease or you haven't.
Well, we're coming to the end, so there's a couple of things I do want to finish off on. But Bod, do you want to come in on that?
No, I just agree with all of that. It's not a great test. The PCR test is not a great test, and certainly you're thinking of doing it on millions of people.
Beautifully put. Okay, so last thing then, and this several people want actually, I'm afraid, David, to do something again, but this is on the convalescent plasma story. So first of all, could I just ask, I'm afraid this is your greatest hit, as it were, but Eleanor, first of all, do you have anything much to add on the use of convalescent plasma? And I'm going to ask David about the stats and the trial on it, but from your perspective, is this something that turns you on, interests you, or?
So I think, the role that convalescent plasma can play is it contains antibodies that will kill the virus. So for people who are, for various reasons, whatever they might be, failing to control their viral load, unable to reduce the virus within their own systems through their own immune response, then giving them something that helps to kill off the virus, that can clearly play a role. An antiviral drug would do the same thing, but we don't have one. So in the absence of an antiviral drug, antiviral antibodies may help. It's not going to be a panacea. It's not going to be something that the vast majority of us are ever going to need. And I think just looking at I'm not quite clear, and Andrew may have a better view of this, quite who might benefit from convalescent serum. I'm not entirely clear from a clinical point of view how many people might actually benefit.
Okay. Now, David, you finished your, when you were on, talking about the Donald Trump press conference with the head of CDC, namely FDA, I do apologize, dear, that convalescent plasma was proven to reduce mortality by 35%. Your response was so scornful that you've been invited to chair the next presidential debate, I believe. But a lot of people said, could you just say slightly slower why that was so wrong? Because not everybody grasps this.
Okay, it's a great thing. So saying it reduced it by 35%, that's it's not based on good evidence, but that mathematically that might not be a bad thing to say, because that's being expressed as a relative risk reduction. In other words, of the proportion who died, their risk is reduced by 35%. There's 35% reduction in the risk of dying. But then he tried to explain it by saying, out of 100 people, this would mean out of 100 people sick with COVID, 35 fewer would die. And which is just ridiculous, because you wouldn't have 35 dying anyway. So One of my carefully chosen phrases about this in the Guardian article was say this is the most statistically dim-witted utterance I've heard in the entire crisis, and he was up against some fairly stiff competition, not least from the president standing next to him on the podium. And so the point is that he was then describing it as a reduction in absolute risk, in other words, 35 percentage point reduction, rather than a relative 35% reduction. Now, it's almost a bit mean. If only he had said, of 100 people who would die of COVID, 35 fewer would die had they got this, he would have been right. Well, he wouldn't have been right because that's not what the evidence says, but he would have been right in terms of statistically, he would have been right. But he didn't say that. And so he, in fact, then, that led to great opprobrium and a great teaching opportunity forever on I think the that's what people between want a relative and an absolute risk.
I think that's what people did want it to be explained slightly. Okay. That's great. Okay, so don't go, but we have to come to the end. And now one thing we've in this series we've been talking about different things. So we've looked under the bonnet, as they say, of behavioural sciences. We've looked at the inscrutable ways of the WHO. We've looked at with you, David, the secrets of statistics. But one thing we haven't done, and you mentioned it, I think slightly tongue-in-cheek, about that you are not a modeler, and you said that with a certain scorn. What exactly is modelling all about? What are its strengths, weaknesses, and do we pay too much or too little attention to it? And to answer all those, we've got next week at this time with Professor John Edmonds.
Oh, great.
Yeah, absolutely. We only get the best. We really do. London School of Hygiene, no stranger to SAGE, no stranger to our screens, and now will be no stranger to this webinar. So that's next week. And the evening before, that's on the Wednesday evening, when we have our longer conversation, not always about COVID. It will be Rabbi the Baroness Julian Neuberger will be on as well. And as ever, like all our sister colleges, we are the RSM under the cosh financially. So this webinar series comes to you free of charge. So if you've enjoyed it, or even if you haven't, do feel free to go onto our website and make a donation. And so with that, I really want to thank our panel who've been sparklingly brilliant, and I'm sure we'll see all of them again. So thank you, Bob, thank you, Eleanor, thank you, David. And once again, thanks very much. And same time, same place next week, we will be back. Good afternoon all.